Hello. Hi, I'm Dr. Omar Bay, and welcome to OBHealthy's The Doctor's Lounge. I'm so happy that we can bring this to you today. We have the physicians that'll be coming on because understand that it is summer and they have family and hospital obligations, so they'll be coming on as we go forward. But what I have the esteemed Dr. Kendall Sprott here, and he and I will start this off, and we're going to rock and roll. Understand that the physicians that are part of this webinar are here for two reasons. Number one is to advance the education of health in people of African descent. And number two is to tell young Black males that, yes, you can be a physician. That's so, so important. Righty? Understand that our webinar is every second Saturday, 1 o'clock. And if you want to see our past webinars, all you have to do is go to OBHealthy, the website, and click on our YouTube channel. And you can see all of the past webinars. Believe me, they're worth going to see. Education about your health and knowledge is so, so, so. All right. Remember to subscribe to the YouTube so that we can continue to bring that to you, bring this webinar to you, I should say. We want to answer your medical questions. That's so important. That's what this is all about. So if you have a medical question, please type it in. Don't be shy. Nothing's too large, no questions too small. Believe me, we're here to answer your questions. So we want to get back to that. I think that for a while there, we got so much into the details of medicine. I really would love to focus more on answering questions. We have a lot of questions here that has come in over the last 2 months because we were absent last month. And we're going to start off with those, but I want those questions to come in from you out there. And if we're getting a little bit too technical, tell us to pull back. Say, hey, wait a minute, give me put it in the computer and say, wait, I didn't understand that. Or can you explain that again? Or can you go over that again? Or make that a little more simpler? It's so important that you understand what we're talking about, okay? I'd like to thank OBHealthy for allowing us to bring this webinar to you. That's so important because without them, believe me, we wouldn't be able to do this. And the most important thing that I can say before we truly get started is that do not change any aspect of your medical care until you consult your physician. Only your doctor, believe me, only your doctor can truly take care of you from a medical perspective. All righty? All right. Dr. Sprott, it's you and I. Can you introduce yourself, please?
Yeah, I'm Kendall Sprott. I'm a retired pediatrician. I did general pediatrics as well as critical care pediatrics and spent most of my career in academic medicine and hospital medicine.
He's a humble brother, but very knowledgeable. And I respect him 110% because he's my mentor, believe it or not. All righty. What we're going to do is we're going to start off with high blood pressure. And the reason we're going to start off with high blood pressure is because, number one, it's in the Black community, this is a medical problem and it's just all over the place. I mean, personally, my mom had high blood pressure that she dealt with all of her life, taking medications and trying to get it down and kind of keep it down and monitoring herself. And it's something that comes along with side effects. Number one, some of the medications, but other organs, your organs are affected by that high blood pressure. And it's so important, if you have it, to take that medication to make sure you maintain that blood pressure in a stable and acceptable level, I should say, because it's so important. Because when that level gets too high, then bad things happen, and we're going to talk about that. Dr. Sprott, can you start off with just give us an understanding from a basics perspective? What is high blood pressure? Can you just give us a little?
Well, if you think of the two words that are important, and that is blood pressure. The blood is the fluid that circulates throughout your blood vessels, and it goes around through the blood vessels to all of the body parts. And the way that it moves is by the heart's pumping. And then if you think about the heart as a pump, whenever it squeezes down and generates a certain force, which causes there to be a blood pressure within the blood vessels. Now, the size of the blood vessels, and when we talk about blood vessels, there are three kinds of blood vessels. They're the arteries, which carries the blood from the heart to either the lungs or to all the other body parts. And the left side of the heart pumps it to all of the body parts except for the lungs. And then the right side of the heart, the right ventricle, pumps it to the lungs. But the size of the vessels that come from the heart um, determine to a certain extent what that pressure is going to be once the heart pumps. So if the blood vessels are dilated, that means that they are wider open than they normally are, then the pressure is going to be lower. If the blood vessels are constricted and they're more narrow than they normally are, then the blood pressure is going to be a little more increased. The other aspect of this is that when we talk about the arteries, either the pulmonary arteries, which go from the heart to the lungs, or the aorta, which comes from the left ventricle, those vessels have a muscular layer to them. And it's the contraction of those muscles that cause the blood vessels to get tighter. And if the muscles relax, then it causes the blood pressure to get lower. So when you talk about a normal blood pressure, the normal blood pressure is going to consist of those three components: the volume of blood that's in the vessels, how forceful the heart is contracting, and then the size of the vessels. So when we're talking about a normal blood pressure, there are a lot of I'll say data points that have gone into making a determination as to a normal blood pressure. And since we start out with blood pressures from when we're actually before you're even born, when you're a fetus, and then after you're born, there are standards or there are data points that talk about what is a normal blood pressure for a child's age and gender. And without getting into multiple genders, we're just going to leave it as little boys and girls. But in general, they have normal blood pressures and a range of normal blood pressures for a specific age and for the specific sex of the individuals. And so once you go outside of the boundaries, and we're talking about high blood pressures on the high end, you can say that there's a normal range, and once you get to that high end of that normal range, you're talking about a blood pressure being too high. And given the fact that we're talking about the blood pressure as being too high, what normally happens is that if the blood pressure is high, then the heart as a muscle, as a pump, has to work harder in order to get the blood flowing through those two circuits, one circuit to the lungs and one circuit to the rest of the body. And what we're focusing on when most people talk about high blood pressure, we talk about the blood pressure that goes from the left side of the heart, which is sort of the systemic blood pressure, as opposed to the blood pressure that goes to the lungs, which is called the pulmonary blood pressure. And the pulmonary pressures are in general a lot lower than the systemic pressures. But either one of those pressures, if they are sustained over long periods of time, can cause problems. Now, when we talk about the problems, again, if that heart has to pump harder, then the way that's accommodated is that any muscle that works harder gets bigger. And so that pumping chamber, the left ventricle, which pumps blood to the all parts of the body, if the blood pressure is elevated over time, then what you'll see is that left ventricle, that muscle, that muscular part of the heart will start to enlarge. And that's one of I'll say the complications that occur if you maintain a high blood pressure over time. Now, another organ that is responsible for sort of regulating blood pressure is the kidney. And so there's certain chemicals that are released that might cause the blood pressure to contract, that especially the muscles of the blood vessels, or the converse is if there's some other chemicals that work in the opposite direction that cause the blood to relax. So when you're talking about someone having an elevated blood pressure, Either the elevated blood pressure is going to occur because the heart is pumping harder than normal, which is generating more force, or there's an increase in the blood volume, and there are certain things that might regulate blood volume to a certain extent, or that the blood vessels are a little bit more constricted. And so any kind of any individual that has a high blood pressure, it's going to be related to one or more of those factors. When you talk about the opposite of high blood pressure, which is a low blood pressure, an individual is going to have a low blood pressure either because the heart's not pumping as it normally should. That means it's a weaker force that's being generated, or that the blood vessels are dilated. That means that they're wider open, or that there's a lack of blood or decreased blood volume. When we're talking about the easy explanation of a decreased blood volume is someone is losing blood. And if they're losing blood because they're bleeding out, then over time, as the more blood is lost, then the heart will pump harder and the vessels will get tighter. But once you get to a certain point and there's not enough blood that's being circulated, then everything sort of fails. But there's some other things that are included in the blood volume, and that's the fluid that surrounds the blood cells. And that fluid can be increased. And if you have an increase in that volume, your blood pressure will go up. And the real thing to do if you have something like that is you want to give something like a diuretic or something that causes you to lose some of that fluid that's in the blood vessels, and you pee it out. So you heard of these diuretics, you heard of things like Lasix or things like that that cause you to urinate more frequently, and that urination is the removal of fluid that's coming from within the blood vessels. Now, if someone is losing blood and they lose it fairly quickly, then you want to replace that blood, and that means giving somebody blood that either is packed red blood cells, which means that some of the fluid that was drawn out when someone donated blood, that fluid around the blood cells is removed, and so the volume of blood relative to the fluid is changed, and you can give that, and that replaces what's being lost. But if someone is having low blood pressure because the blood vessels are dilated, and that can happen if someone has an allergic reaction where the blood vessels sort of get dilated and the pressure goes. It's not because they've lost any volume, but the blood vessels are wide. And one of the things that you can do in those circumstances is give volume, not red blood cells, but the fluid that will help to expand and raise the blood pressure that way. And so, and then the third thing is that the heart is pumping harder, that it's causing the blood pressure to go high, then you give something that blunts the ability of the heart to contract forcefully, and there's something called beta blockers. But if you have someone that has a high blood pressure, then the treatment of the high blood pressure is going to affect one or more of those three things. It's going to cause decreased blood volume through a diuretic, like Lasix or hydrothiazide, a thiazide diuretic, or you're going to give something that's going to cause the blood vessels to relax, and a number of drugs that are involved in causing the blood vessels to relax. That means that they dilate a little bit more, or they can take something that affects the heart, a beta blocker. And some of these medications combine either two of those things, something that affects the size of the blood vessels, makes them dilate, affects the blood volume with the diuretic, or they have a beta blocker or something that causes the heart not to contract as much. But one or more of those three factors are involved in causing the blood pressure to get lower. And again, if you have blood pressure sustained over a long period of time, it can damage the heart. You can also have issues where it damages the kidney. And so it becomes important. And very often, you don't really know that your blood pressure is elevated unless it's measured. Now, in these days, in the older days, what you did is you had a blood pressure cuff and you can take it. And then they started to make these electronic devices where you can, it reads it and gives you a digital display. Now they have these newer devices where a watch or something that even you can put on your phone, it can tell you what your blood pressure is. But there are natural things that occur. If you get excited or you're stressed, your blood pressure can go up. And that's something that you need to be aware of in terms of whether or not there are things like that that are important that cause your blood pressure to go up. Most of the people that have high blood pressure, we really don't know the actual cause of why it occurs, and some people think it may be related to genetics or related to the diet that you have. You know, when we talk about excess fluid, one of the things that might cause excess fluid to accumulate is related to salt. Salt is something that obligates water. And if you have an increase in the amount of salt that you take in on a daily basis, then there's a slight increase in your blood volume that will occur related to that, and a slight increase in your blood pressure. And so one of the things that might be advised if someone has a high blood pressure is you reduce their salt intake. And what happens is that your kidney is what regulates how much salt you keep in your body. And so if you're taking the same amount of salt in every day, then your kidneys are getting rid of the same amount of salt that you take in, because it doesn't like to have an increase in that salt content, because that increase in the salt content not only can lead to issues with blood pressure, but also can lead to increases in the amount of fluid in your body, and that's called edema. So you might see people that have swollen legs or things like that. And that's because they have increased salt and increased water related to it, and that sort of causes the accumulation. So when we think about high blood pressure, you start to think about those things that might be affected by the blood pressure over time. And so you need to look at whether or not you're seeing some of the complications related to prolonged elevations in your blood pressure, like that left ventricle getting larger because it's been working harder over time. And you'd like to try and address those things before they happen. And so if given the ability to take your blood pressure, you want to make sure that the blood pressure is not just elevated because you were excited or you were nervous when you went to the doctor's office. And so you'd like to see that the blood pressure that is taken by yourself when you're not stressed or you're not nervous or anxious. And you want to see that it's above the normal levels that you have for your age and your sex over time. And if you go and have it elevated consistently over three measurements, then you need to see about the doctor making some recommendations about what you need to do to lower it. And that's what we do in children. If we see someone going to come in that might be nervous and the blood pressure is elevated, we take it at the end of the visit and see whether or not it's come down, or we ask them to come back and we take it a few more times to make sure that it's not just something that's a one-off or an occasional thing, but it's consistently elevated. And then we need to make sure, because you can have children that have elevated blood pressure, and then the complications related to that will occur a lot earlier.
Excellent. That's an excellent review. Let me just ask something, Dr. Sprout. When and one of the questions that came in is, how do we determine, or what's happening in the body that allows us to determine the top number and the bottom number? What are they called, number one? Number two, how does it happen when the left ventricle, which is the power ventricle of the heart, contracts? What actually happens to cause the top number in your blood pressure and the lower number in your blood pressure? What's happening in our heart?
So, when one of the things that we know about is that the heart makes these sounds, blah, 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 blah. And so when that heart squeezes, okay, there's a certain volume of blood in that ventricle. And when it squeezes the blood out of the ventricle into the aorta. And there's actually a valve between that ventricle and the aorta, which is that major vessel. So when it makes that squeeze, then the blood comes out of that ventricle and then it expands into the blood vessel. And then it relaxes. And so you hear those two different sounds. And when it contracts at that highest pressure, we call that the systolic pressure. Mm-hmm. And then when it relaxes and goes down before it starts to contract again and reaches a low point, we call that the diastolic pressure. And so there's a resting pressure that the heart has to work against all the time. And that resting pressure is the diastolic pressure, and that's the pressure that it's working against when it squeezes. So if you have a high diastolic pressure, then when the heart contracts, that first contraction, then it's going to make the pressure higher than what it normally would be, because the resting pressure was higher than what it should be. And so when we look at that, you look at the highest pressure, and when you talk about some of the complications of high blood pressure over time, it could be stroke. And so that might mean that you might have some damage to the brain, because either there's been some blood loss related to that, a hemorrhagic shock, or it could be ischemic, where there's a narrow amount of the blood vessels in the brain that causes a decreased amount of oxygen that's there. So the high pressure is the one that might cause the damage, if you will. But the lower pressure, if that's elevated as well, means that the higher pressure has to be larger in order for the blood to continue to flow. And so you need to monitor both of them. And so and over time, as people have been looking at this for a number of years. They have these huge studies that look at what's the range of pressures that are considered normal. And again, they look at it now in older individuals in age, and it seems as if the normal blood pressures that they're talking about, they're kind of making the consideration of hypertension at lower numbers than they did, 15 and 20 years ago. My view is that if everyone is an individual, if you will. And I think that some individuals that might have pressures that are considered high may not have any of those complications that we normally see, like increase in the size of the ventricle. And in that case, it may not be that there's a big issue that is involved, but you can't make that determination on your own. That's why you should go to your family physician or your internist or the med peds, who might want you to see a cardiologist to see whether or not there's a cardiac issue or a cardiac complication, and then see how you might go about trying to manage it so that you don't have some of these complications over time that can lead to all sorts of issues related to your long-term ability to live a healthy and long life.
Excellent, excellent. Dr. Patrick Anderson, this is what we're going to do. Number one, I would like for you and Dr. Aluya to introduce yourselves, and then we're going to keep going forward. We got some questions that's come up as well. Dr. Anderson, please start off.
Yes, hi everyone. Patrick Anderson. I'm a GYN oncologist. I take care of women with cancer, do surgery, chemotherapy, health plan, radiation, and so on and so forth, and participate in a broader scope of women's health, of which hypertension is often a big issue for me and some of the patients I have to take care of, and especially some of the young pregnant women. It's an honor to be here. Thank you.
All righty. Dr. Aluya, hello there, brother.
Yes, hi. Good afternoon. It's a pleasure to be on again. My name is Nelson Aluya. I'm an internist, internal medicine specialist with great interest in diabetes. I call myself a medical advocate. I've had multiple hats. One time president of the New Jersey Medical Association, chairman of the Nigerian Physician Association, the state of New Jersey, former medical director of NCAC, and a medical consultant right now as well. It's a pleasure to be here amongst my brothers who are very knowledgeable. And I always say, and I write, with a combined age in practice of over 180 years or more of clinical knowledge. So it's great to be here. Thank you once again.
Dr. Aluya, didn't you neglect to mention you had some pediatric training when you were?
Yes, I usually say that I'm med-peds trained. I do pediatrics. I still do pediatrics, actually. So yes.
I know you're getting older, but I didn't think you forgot that you did pediatrics.
I hope it's not hypertension.
My interest is sickle cell, really.
All righty, all right. Well, we're gonna have to key on sickle cell because we haven't done that one in a long time. We're gonna have to do a show on that one. Patrick, Dr. Anderson, what we're gonna do is you have your hand up, so you'll go ahead with that. But there are two questions that I want to get to right after you. Okay?
Yes.
Go ahead, Patrick.
So for both Dr. Spratt and Dr. Luya, who two people I lean on when things get complicated. So the numbers that Dr. Spratt talks about, the systolic and the diastolic pressure, that's a reflection of what happens to one side of the heart. Can you, either you guys expand or talk about what happens to the pressure on the other side of the heart? Do we view it in the same way?
So I think, again, when we talk in general about hypertension, people sort of focus on the systemic hypertension. But if and this really goes back to the circulation of the blood before a baby is born. But in general, if you think about the volume of blood that's being pumped, there's probably an equal amount of blood that's leaving the right ventricle and going to the lungs as there is leaving the left side of the ventricle and going to all of the rest of the body. But what tends to happen, before the birth of a baby is that and I'll talk about this, maybe a little complicated, is that the vessel size in the baby, that are those vessels that are going to the lungs, are completely constricted off. They're just
Dr. Clark, excuse me, Dr. Spratt. We're talking about a baby that has not been born yet. We're talking about right. Understand.
And the reason that these vessels are completely obliterated is the baby's not breathing in oxygen.
Right.
So the baby can't have blood that's going to pick up oxygen when there's no oxygen that's going to be there. But as soon as the baby is born, okay, those blood vessels that allow blood to get to the lungs start to loosen up. And as they loosen up, and again, when they're very, very tight, the pressure there is very, very elevated. And what happens once that baby is born and takes the first breath, then the pressure in those vessels starts to go down. And it goes down gradually, but it starts to go down, allowing blood leaving the right side of the heart. Instead of going out into the rest of the body as it did before the baby was born, you now start to have blood that starts to go to the lungs. And again, as that pressure gradually decreases over time, the volume of blood that goes to the lung also increases until they reach the balance. But the pressures that are in that lung are a lot less than the pressures that's going to there. And so the muscular size of the right ventricle is a smaller muscular size because it's not doing the kind of work that the left ventricle is doing. Okay, now there are all sorts of things that can happen when you have holes in the heart and you have these communications. But if you think about it, there's sort of, at a certain point after the baby's born, two completely circuits. The right circuit, blood goes from the right ventricle to the lungs, returns back to the left atrium, the chamber above that receives it, goes to the left ventricle, and then pumps out. And all of this blood continues to go. Now, if you start to have issues in terms of the pressure that's on the right side, and you can have an increase in pressure, again, we talked about this before, same three reasons. If there's an increased volume of blood that's going to the lungs, that will increase the pressure. And remember that if we have the right side of the heart being low pressure, the left side of the heart being higher pressure, and then there's a communication or a hole between those ventricles, then the blood's going to follow the path of least resistance. And so the blood's going to flow from the high pressure left ventricle to the low pressure right ventricle. And therefore, instead of having half the blood volume going to the lungs and half the blood volume going to the rest of the circulation, more than half is going to go to the lungs and less than half is going to go to the circulation.
Yeah.
Now, the body doesn't like to have less blood going to the circulation, to the brain and the kidneys and the heart and the liver. And therefore, they'll make adjustments. They'll say, even though there's less volume, we're going to pump harder and we're going to make the vessels tighter.
Mhm. Yeah.
And the increased blood volume in the lungs is going to lead to increased pressure in the lungs, those blood vessels, because there's increased volume. And we said over time that that right ventricle that's used to dealing with a pressure that's lower, if it's pumping a larger volume, those blood vessels are going to have a higher pressure, and then that right ventricle can start to enlarge as well.
Yeah.
And so the issue of pulmonary hypertension is something that you know can occur over time as well. And so if we have a baby that has one of those communications that allows blood from the left ventricle going to the right ventricle, larger blood volume, that can have the same kind of complications over time in terms of the bad effects of those high blood pressures. And so you like to correct it before that pressure remains elevated over time and may become irreversible in terms of the pulmonary hypertension.
Yeah. That gets a little detailed. Let me see if I can explain it from an adult viewpoint. The pulmonary hypertension and the difference between high blood pressure in the lungs as opposed to high blood pressure in the body itself, it's two different things. Okay, and treatment is very different. And with Dr. Anderson, when you ask that question, what you're talking about is the heart. You have to explain how the heart functions. Number one, that you have blood in the veins that come up to the right side of the heart. And this blood has already given its oxygen up. So you have that blood coming up to the right side of the heart. It goes through two chambers. And then from the right side of the heart, it goes into the lungs. Now, the lungs, those vessels from the right side of the heart into the lungs are called the pulmonary arteries, and that means the lung arteries. And even though you have blood that's coming in from the vein side, when it goes from the heart to the lungs, it's called arteries. It's a little confusing, but that's how it is. Once that blood goes through the lungs, guess what it does? It attracts oxygen. And all of the hemoglobin and all the red blood cells and all grabs oxygen while it's in the lungs. That blood is in the lungs. Now understand that blood will from there go back into the heart, but this time it goes into the left side of the heart. In going into the left side of the heart, then from there, that's when you get the blood pressure of the body. It goes into two chambers of the heart on the left side. That last chamber is called the ventricle. And when that squeezes, that's what Dr. Sprock was talking about. That generates our blood pressure in our entire body. When you're talking about high blood pressure in the lungs, though, we're going to go back to that vein side and the blood that's coming back to the heart on that right side. What happens for many different reasons is that side of the heart, when it comes, the blood comes into the lungs, it should be a completely low pressure system. There should be no back resistance to that blood going into the lungs. But there are occasions and things that happen to us that cause that blood to have resistance going into the lung. That's what pulmonary hypertension is. Now, Dr. Sprocket said sometimes it's the volume, things like liver disease that causes extra volume, things like there are diseases that will affect the lung tissue itself. And if you get scarring on the lung tissue, then those vessels that go through the lung, all of a sudden they get kinked. And when they get kinked, then that means that that blood has a harder time pushing through the lung. That's pulmonary hypertension. So people that may have sarcoid, or people that may have things like severe lupus with scarring on their lungs, or there are many things, bad COPD, where people have emphysema. They may, all of those vessels have they will not allow the blood to flow through easy. So that's what pulmonary hypertension is, the problem of getting that blood to flow through the lungs without any back pressure. And once that that tension or that hypertension develops, it's very, very difficult to treat. And I'm going to end just with this. Treatment for pulmonary hypertension is very difficult. The reason being is that you're asking a medication to come in and lower the blood pressure in the lungs, but not lower the blood pressure in the rest of the body. Medication just isn't that smart. If it's going to lower one, it may lower the other. There are a few medications that we try to use that can have this effect, but we don't have good treatment for pulmonary hypertension. Hopefully that gave some. Dr. Anderson, go ahead. You have your hand up again.
Yeah, so just a follow-up on that. So, we often talk about the consequences of blood pressure, hypertension, which, as Dr. Sprock said, that's systemic hypertension. Just for the listeners, are those consequences the same consequences as hypertension on the right side of the heart?
So I'll expand a little bit more. And what Omar, Dr. Bay talked about are some of the issues, I'll say, that are mechanical issues with the flow of blood in the pulmonary circuit. And one of the things that he didn't mention that can also be a problem is some individuals might have blood clots, and Jordan's not on, in the lower extremity. Those blood clots, if they come into the venous system, will end up in the lung. And when they end up in the lung, one of the big things is if it's big enough clot, it can be a real disaster. But sometimes it's just small clots. And then what happens with those small clots is the blood can't get through. And then it starts to build up behind where the clot is. And so sometimes they might want to give, like, a blood thinner or things like that. But the other thing that we talked about, and it's the same thing on the left side of the heart, is the vessels that are there are regulated in terms of dilating and constriction. And there sometimes can be issues, and we don't know why those blood vessels become constricted and narrow. And when they become constricted and narrow, that causes the pressure to elevate there. And again, what we talked about before is when the heart, those chambers that pump, that right ventricle, when it pumps, if it's now having to pump against a higher pressure, that when that blood leaves and goes there, then the pressure goes up even higher. And what then happens is the blood vessels that have the muscular layer around them will also start to get bigger. And if they remain bigger over time, they will just start to march on and close off entirely. A very, very significant problem. And so there are medications, as Omar talked about, that they try to be selective in terms of trying to cause those vessels to relax. And they have some medications that will cause them to relax more than the other vessels on the systemic side. But there is no question that one of the things that in my career, I talk about horrible deaths. And one of the horrible deaths is where you don't have enough oxygen. And if individuals have certain diseases, and there are other kind of connective disease, that can cause problems in terms of the lungs and these vessels. But if you think that there's a point in time where it's impossible to reverse that pulmonary hypertension, and those vessels just continue to narrow over time until they're completely gone, those individuals suffer dramatically because there's not an alternative to get oxygen that's returning to the body if it can't get to the lung. And so, yes, you can have problems. And again, there are valves that are there between the various chambers of the heart and then the chambers that leave the heart going into there. And if over time you start to have pressures that exist, you can start to have problems with those valves. And that will allow blood to back up and back up pressure. So the issue is of those things, and it may not be as easy to diagnose, okay? in terms of the pulmonary pressures. It's not like you have a blood pressure on your arm that's ever to measure. You have to have more sophisticated studies that are looking at what the predicted value of the pressures are in that pulmonary circulation. And so it's not as easy to diagnose in terms of to actually measure those pressures. But the fact is, if you don't have oxygen and you don't have blood sugar, that's another thing, you can't survive. And so the issues of having trouble with blood getting into the lung, or even in getting to parts of the lung, that means that the other parts that aren't receiving blood, or the blood's getting there but it's not receiving oxygen, that means that your body is relying on smaller parts of the lung to generate all of the oxygen that's needed for the rest of the body. And so it's an extremely serious thing and not something that needs to be neglected. And the earlier you can figure out that there's an issue, then there may be some interventions that you might try. But it's a very serious condition. You talk about all the other parts in the systemic, but the lungs are probably the most important organ in terms of being able to get oxygen to the blood, and then that blood getting to the rest of the body.
Dr. Luya, yes, speak up,
Yes.
please.
Right. Yeah, so I mean that's incredible explanation has been done. But a few things that we need to take away, that physiology and nature has arranged for us to be able to be alive and live the way we are. Number one, oxygen is the most potent or the best vasodilator ever. And that's the reason why it's in our lungs. When you say vasodilator, meaning it's the best unit to relax the lungs. And once there's a denaturing, meaning there's a mismatch between the way oxygen gets into the lungs and how it gets there, then things begin to really happen to the vessels that may result in pulmonary hypertension. Now, when we talk about pulmonary hypertension, or when we talk about hypertension in general, the one most people talk about, like you said, is the systemic, meaning around the body, the one you measure with your arm. Now, when you talk about pulmonary pressure with the lungs, that's a little different. The pressure is right within the lungs. We do have normal pressure within the lungs. The normal pressure within the lungs is usually the mean pressure, pulmonary arterial pressure, anything less than 25, like I said. Now, 25 to about 30 is mild. 30 to 35, 45 is moderate. Anything above 45 becomes high. Now, how do we measure that? And that's why a lot of the time when you tend to have anything that has to do with the heart, you're having shortness of breath, your legs are swollen, or you can't breathe, you can't walk up to the usual stairs that you usually walk. You walk a flight of stairs running. Now you have to wait in between, or you feel short of breath. You used to walk to the mall or a block. Now you feel short of breath and you have to stop. Then your doctor will have to send you to go see, the cardiologist, or ask you to do an echo. Now the echo is that, thing that you put in the heart. They put a gel on you and then measure like they do with the ultrasound. Like they do with the babies. So when they do that, they also measure the power of your heart, which is called the ejection fraction. They also look at the structure of the heart, but other things they also measure is the pressure within the heart as well. It gives you a rough estimate. Now, recently, I found out one of my patients has a pressure that's 50 and above, and that's really high. And that happens so suddenly. And we have to take drastic steps in addressing that in itself. Now, anything above 45, when they measure that, it's very high pulmonary hypertension. Now, pulmonary hypertension can cause from two ways. There's the primary and the secondary. The primary one, we don't know what happens. And it's usually very common in women, unfortunately. And we have no reason for it. And they usually picked up a little earlier. Young women, younger age. Now, that, unfortunately, I'm sure Dr. Anderson would agree, is the only time where you don't allow that kind of woman to go into pregnancy, because it's devastating if someone with pulmonary hypertension carries a baby. It's usually very fatal. So, and that's the primary one. We don't know what caused, maybe from birth or from something, a virus or whatever along the line of their life. Now, the secondary one that Dr. Bay had talked about can be from medications. It can be from medications. It can be from infections. It can be from diseases like sarcoid, rheumatoid arthritis, like you all talked about. Some medications they've talked about is amiodarone, has been associated with it. So that's why a lot of the time when somebody is on sending a medication, we tend to look up those and we keep them in mind to see if all of a sudden they begin to get short of breath. The lady I just talked about was put on some other medication that had looked like amiodarone. So I had to call the doctor like, hey, this patient is on these meds. Do we need to stop this? Now, infections, again, one of the one we noticed recently was COVID. COVID itself causes severe alteration in the oxygen.
Dr. Aluya, I'm going to have to stop you. All of a sudden, your volume went down. Did you decrease your volume some?
Yeah, maybe it's
by
the
accident
here. Yeah, okay. Yeah. So where we see people who were walking on the streets that had COVID, looking normal, all of a sudden they pass down and then they die. And we didn't know what, this is totally new to us. And what we found out that somebody can have COVID and his oxygen level, which ideally you and I sitting down, will be like 99, 100. And when you're asleep, it's 95. Their level can drop down to 40, 45, and they may still be walking. It's called happy hypoxia. So that alone can also result in pulmonary hypertension eventually. And we talked about blood clots that can move from the leg into the lungs. That again can also result in that. So, but coming to medications, again, oxygen is the number one. Some people try to use a blood pressure medicine called a calcium channel blocker, amlodipine, initially. Now, we also have the medication called Revascil. Revascil is actually Viagra in its form. So we tend to do that just to help ameliorate all of those. There are also other medications that immune modulants that have been used to help reduce. But like Dr. Bay said, it's very difficult to control, but it's something you have to manage in entirety, from the heart and to the pressure as a whole. So it's important that we pay attention to all of this. But above all, please do not smoke. That's one of the big issues, again, that we tend to, have all of this with severe pulmonary hypertension. And on top of that, when you gain weight. So
Dr. Aluya, if we could bring your volume up just a little bit, it would be better.
okay,
Omar,
let me see if I can increase my volume.
Omar, I just wanted to make one point, and it might help related to Patrick's question. And Dr. Aluya mentioned something called the mean arterial pressure. And the mean arterial pressure there's a formula for it. If you say that somebody has something like 140 over 80, 140 is the systolic pressure, 80 is the diastolic pressure. There's a formula that basically says that the mean arterial pressure has got to be somewhere in between, and it's weighted towards the diastolic. So mean arterial pressure is going to be the systolic pressure, 120, plus twice the diastolic pressure. So that's 80 and 80, which is 160 plus 120. And then you divide it by 3. Okay? So you're going to see that it's going to be somewhere between that 120 and the 80 is going to be maybe 90 or 95. The same thing you can say for the pulmonary pressure. The pulmonary pressure is going to have a mean pulmonary pressure. Same issue. The systolic pressure, which in the lungs, that's why we say it's a low pressure circuit, is going to be around 20. Systolic 20 versus a systolic of 120 for the systemic. In the lungs, it's going to be maybe around 20, and then the mean arterial pressure is going to be somewhere around 12. And so you're talking about a low pressure system in the pulmonary vasculature, as opposed to a higher pressure system, a much higher pressure. So it's easier for the blood to flow from the right ventricle into the lungs than it is for the blood to flow from the left ventricle in the aorta or in there. And so we're talking about a lot smaller pressures in the lung. But once you start to have increments in those pressures, you start to have the same kinds of negative effects in terms of the vessels getting tighter and then the heart having to pump against a higher thing, even though it's pumping against a smaller volume, because it's coming up with a higher pressure, that right ventricle has to work harder. And so it's two different circuits, but these pressures are very, very different. But increments in the pressure have the same kind of negative effects on the ventricles.
Right. I'm glad you answered that, because I think
Excellent.
that's initially what Dr. Anderson was asking us. I was thinking about other things like stroke. That's more of I would say, left-sided heart problem than a right-sided heart problem. And not unless you have one of those holes in the heart where the blood flows through and misses the lung. Things like heart attacks, that could happen on the right side as well as the left side. And things like kidney problems and things like that. It's not usual with right-sided heart failure, but the body works as a unit, so any of this is possible. What I wanted.
Just one other thing, just to think about is, when you talk about that blood flow going to the lungs, it's blood flow going to balloons. It's really not anything that has, weight or tension or anything like that. And so it's sort of a low pressure, easygoing kind of a thing to deal with. But when those vessels get tight,
Right.
it changes the whole dynamic.
Changes the whole dynamic. Yeah.
Yeah, and I think this makes education in primary care so much of a challenge, because how do you take the time to break it down so your patients, who would often looking for simple answers,
right,
understand that the consequences of being screened thoroughly?
Well, Patrick, I think the most important thing is for the doctors to know what they should be screened.
Right.
And I would say that, I spent 15 years doing critical care, so I had to learn all of this stuff because I dealt with patients that had these kinds of problems. But, I think, and increasingly now, I think that, the axiom is that most physicians that are taking care of patients and primary care physicians are no longer taking care of their patients in the hospital. The doctors that are taking care of the patients in the hospital are taking care of them when they get really sick. And so because they're not needing to take care of those patients or those kind of problems in the hospital, they don't tend to learn as much as they used to have to learn in order to deal with these issues. And this is something I think this is going to go ongoing. And so I think, we have Dr. Luya, who is a primary care physician, but he's very knowledgeable about a lot of these things. Unless you've been involved in taking care of very sick patients, you might not be familiar with this. And again, you rely on specialists to come about with making these kinds of issues, because the issues of trying to do a pulmonary mean arterial pressure or measuring the pressures deal with cardiologists. The ordinary primary care physician isn't going to be aware of those kinds of issues.
Yeah, those are things that we use in the ICU all the time. But you're right about that. Pulmonary issues such as those, the primary care does would even come in contact with a mean arterial blood pressure.
And I'll tell you this, that's a huge disconnect with what's happening. And unfortunately, it's going to get worse. It's going to get worse because the training in teaching hospitals now, it's very different from the way we were trained. That's one. Two, and when we come out, the exposure that these young and younger doctors are getting with the hospital and everything else, it's very different. And unfortunately, who suffers the most? It's the patients. And now one of the big discord that is taking place is the connection between the doctors in the hospital and the doctors who are outside. Now, a lot of things happen in the hospital. They even take patients to surgery without their primary doctors knowing about it. And then when things go on, there are complications, and they discharge you, you go home. And then that's it. Now, you are seeing the doctor on the outside who had no knowledge that you had surgery, you were in the ICU, all of those, and now he's faced with all this, barrage of complications that you had while you're in the hospital, and he has no knowledge about it. And it's a big, big issue. Reconciling medication, reconciling what happened to you. And the patients are not very well informed as well. A lot of them don't know what happened to them. Some of them don't even know the surgeries that they had in the hospital. So one of the reasons why we're doing this is to get our people and our community very informed about their rights and responsibilities when it comes to their own healthcare. Because, I mean, as Black doctors, we are here to stand in the gap for you, but at the same time, you must be knowledgeable about what's happening to you as well, so that you can help your doctor best take good care of you. So, and that's why we're doing this. It's really sad, but and unfortunately, newer and newer things are coming up every day, to the point where it's like we're faced with technologies, rushing at you at 100 miles per hour, and you have to keep up. And not everybody is willing to keep up, or in the space where they want to keep up with what's going on. Again, that's why a platform like this, where people who are in the space of looking out for what's happening out there, especially when it comes to our community, because at the end of it all, the Black and Brown communities suffer the most when it comes to all of these outcomes. So, like I always say, there's an African adage that say, if you hear good news, you listen with both ears. But you just still listen, you pass on that information as well to the community, so that we can together help and save our communities.
Oh, this is a perfect time to take a break. And when we come back, I want to answer questions, because we got quite a few questions to go through. I'm so happy that the audience out there is connecting and asking their questions, and we got to get to those. Number one. Number two is that, I would just like for each and every one of us to introduce ourselves one more time, because I'm sure people have come in and we hadn't introduced ourselves, or they missed our initial introduction. Dr. Sprout, please.
Yeah, I'm Kenny Sprout, retired pediatrician, did critical care for 15 years in hospital-based, and was academic pediatrician for all my career, pretty much.
Excellent, excellent. Dr. Patrick Anderson.
Yes, I'm Patrick Anderson. I'm a gynecologic oncologist. I take care of women with cancer of the reproductive system. While I don't practice primary care, a lot of my practice is really integrated into primary care. And just to expand on, Dr. Spratt said, a retired, right? My gray beard is, I was with students, and I was always anxious when I go to Spratt rounds, because common things are common. Everyone expects me to know how the lung function, but Dr. Spratt he's not interested in that. He expects you to know that. He's going to ask you, how do you calculate the mean arterial pressure on the right side, right? And that's what's missing in training today. With the technology coming at you, and folks needing to understand the different ways of doing measurements and calculation and monitoring patients, we need to try and bridge that gap between what happens to the primary care on the outside and what happens to the ill patients on the inside.
Hey, Patrick, I asked these other two guys the same question when they came under me.
You sure did. You sure did. All right, Dr. Aluya, please.
Yeah, I'm Nelson Aluya, medicine pediatrics trained, a medical advocate, a medical consultant. I run a primary care center right now in Irvington, New Jersey, but I've been a CMO, president of multiple organizations here in the state of New Jersey, and also assistant professor of medicine at the New Jersey Medical School. It's a pleasure to be here once again. Thank you.
Excellent, excellent. And I'm Dr. Omar Bey, a pulmonary critical care physician with a subspecialty in nutrition, and just so elated to be here with these brothers. Understand that our webinar is every second Saturday at 1 o'clock. And please, if you have family members, because it takes a village to do something like this and to really get out there and let our people know what we're doing to educate them about their health, because nothing's more important than your health. So it takes a village. If you have a Facebook page or anything like that, when we send out the advertisement, put it on your Facebook and send it out to all your friends and family. Let them know that we're talking medicine here and that it's important that they come in and connect with us. The most important thing that I can say is please do not change any aspect of your medical care before you consult your physician. Only your doctor, believe me, only your doctor can truly take care of you from a medical standpoint. Also, thank you, OB Healthy, for allowing us to bring this webinar to you. All righty. And what I'd like to do at this particular point is tackle some of these questions, and let's rock and roll. Here, the first one is, and this is interesting, I've always had low blood pressure. I'm 40 years old now. Lately, I have seen it go up to 101/76. How you like that? But sometimes it goes back down low and to low blood pressure. What can I do to increase it to normal, they ask. Now, I also observed that my daughter, 10, has a low blood pressure, which I believe is generated from me, or should I not worry about it? Kendall, can you start off with this one?
Well, I'll start out at the child. As I said before, that there are charts, just like when you have a baby that starts out doing very little, and there's a growth and development charts. There are charts that relate to blood pressures, and there's a range. And like I said, the range of the blood pressure. And the real point is with a low blood pressure, whether or not individuals are having symptoms related to the blood pressure being low. Because the fact that you have a low blood pressure may be a normal blood pressure for you. And so, when we talk about the reason that the blood is circulating is to get oxygen to all parts of the body. And you need to get it at a certain amount of pressure. But Nelson mentioned sickle cell, and that's sickle cell anemia, where the actual number of red blood cells circulating is less, and therefore the amount of oxygen that's being carried around is less. The body makes accommodations for that. One of the accommodations is that the heart itself sort of dilates, if you will. That means it starts to squeeze out a larger volume of blood with each stroke than it normally would in order to get a larger volume of blood circulating. And then the other piece to it is not only the volume that's being expressed from the heart, but how rapidly the heart is beating. Okay? And so you want to put it into context is the heart beating faster in order to get the blood around because there may be some dilation in the size of the blood pressure? And it's probably not. There are some athletes, especially athletes that train, on a rigorous basis, that are utilizing oxygen at a faster rate because of the muscles, but they have accommodated for what they're doing, and they don't get tired. They don't start to generate lactic acid. Lactic acid is what the muscles generate when they don't have enough oxygen. And you'll see that some of those individuals, they say the muscle burn. That's part of the issue with not enough oxygen. But if there's enough oxygen that's getting around at a normal heart rate, then that's probably not an issue. Okay, the same thing can occur if someone has a low pulse rate. If someone has a low pulse rate, that means that the heart, instead of beating maybe 85 times a minute, is at 60 a minute or 45 a minute or something like that. And they're starting to become symptomatic. They can't, as Dr. Aluya talked about, they can't walk well at a certain amount, and then they get tired, they get short of breath. And shortness of breath is maybe not related to the lungs per se. It may be related to the amount of oxygen that's sort of needed. But if you don't have a high enough heart rate with a normal blood volume, then you're not getting enough oxygen to the tissue, and it's a problem. And that's why they say that those individuals may need a pacemaker. Pacemaker means that, if it drops below a certain level, the pacemaker kicks in to get the heart rate up to higher. So the real question is, number one, for the child, what's the blood pressure, and whether or not the pediatrician can give you oh, she's on this chart and she's maybe between, you know, and again, they talk about these charts in terms of percentiles, okay? And so they go from 1 to 100, if you will, but they say if they're in the between the lower fifth percentile, it may be abnormal. But if you're between the fifth and the 95th percentile, you may be normal. So the question is for her to have this conversation with the pediatrician about where is her blood? Is it in the range of normal for her age and her sex? Now, another question that came up, and that is, what's the effect of obesity on the blood pressure? Mm-hmm. And that's sort of an interesting phenomenon. When I did it way back in the day, internal medicine, they said that obesity had no effect on the blood pressure. Okay, and that was the axiom. Now, the part of the issue is about the measurement of the blood pressure. And the measurement of the blood pressure is important because that blood pressure cuff, the bladder, which is the thing that has the air, needs to be a certain size as it relates to that part of the arm that's being measured. And very often, if you don't have a large enough cuff, if the cuff is too small, it'll give you sort of a false elevation of the blood pressure. And if the cuff is too big, it can give you a lower. And so part of the issue is whether or not, for someone that is very obese, whether or not they have the right blood pressure cuff or the size to give an accurate blood pressure. And so that becomes important. But the issue of all the other issues that are now we know are involved in obesity that might relate to diabetes and other kinds of issues and problems related to the vasculature, it's important to sort of get an understanding of that. But by and large, it may be that, you know, and again, she didn't talk about how much she exercises or what she does, but it may be that her blood pressure for her is normal. Mm-hmm. Certainly all the bad things that we think about in terms of, you know, damage to the kidney and damage to the heart and the enlarged muscles, you don't have with low blood pressure. You usually don't. So the question is for her to have a conversation with her doctor about her blood pressure and her heart rate, and the daughter with the pediatrician. And this is something that we touched on before, and it's not in a good way. And that is the amount of time that physicians are actually spending with the patients is decreasing over time. You know, the physicians are on the clock. If you're coming for a well visit, you got X number of minutes. If you're coming for a follow-up, you got less number of minutes. And so, and if you get, and they're watching the clock, and if you start to get enough, then they said, okay, you're gonna have to come back. We're gonna have to schedule another visit in order to accommodate this kind of thing. And so it becomes important for you to, number one, have a list of the questions. And again, very often when you are going to a physician, as a patient portal where you can ask questions beforehand, and you should try and get as much information as you can from the doctor when they have time to communicate via the patient portal, and therefore when you go, they can actually pay attention to the things that you are most concerned with. But I think for obesity, the issue is, number one, is the cuff size right? To give you an accurate blood pressure. And then number two, if you're talking about low blood pressure, where do you fit in terms of the range of normal? And because the low end could be normal for you.
All right, excellent. Patrick, you have your hand up.
Yeah, you know, just to dovetail on what Dr. Sprott was saying is, you know, you also need to understand and know what's normal for you, and whether this new blood pressure is that a change from what used to be, because that may be an indication that something else might be going on. Your regular heartbeat, your pressure may be normal with a regular sinus rhythm, and I'll leave it to Dr. Luya to explain what a sinus rhythm is. And now your blood pressure is lower because that rhythm is not normal, and the ventricles are not responding in a timely way to pump as much blood as it needs to. So now the pressure is actually lower than it ought to be for normal physiologic function. And then there are diseases that cause these kind of abnormal heart rhythms. So that's why it's important for us to understand what's a baseline for you, and whether this blood pressure that you're now seeing is a lower blood pressure, is that a change from your baseline going lower? Just the way we view it, if that change is a higher blood pressure.
Yeah, the thing of it is that, and I think Dr. Sprock mentioned this. The number one thing is that you should go to your primary and see what the track record has been. If this has been a track record that you've had blood pressure that is low over many years and you're not symptomatic, no shortness of breath, no chest pain, no dizziness, things like that, then that's your blood pressure. And just because it may fall out of the norm or out of as he said, it's a bell-shaped curve and you're in the lower part of that bell-shaped curve. It does not mean that it's abnormal for you. But if by chance this particular question for this person, if they have not been to a doctor and does not follow a doctor on an ongoing basis, and this is occurring, then I would say yes, she needs an appropriate evaluation, definitely. And as Dr. Sprock definitely clarified as far as the daughter is concerned, and I'll let him. I think he's already clarified that. Let's see if we have some more. We have plenty of questions, not even see if we have some more. Okay, we answered the second question. What is the effects of obesity on the blood pressure? Okay, hold on. Okay, here's one. Can an enlarged heart return to normal size with medication and lifestyle changes? If so, how long might it take? Now, that's an interesting question because, and I'll start off with that one. Dr. Aluya, maybe you can jump in on this one as well. The heart is a muscle, and just like any other muscle, if you work it hard, then guess what? It's going to get enlarged. The unfortunate aspect of the heart muscle is that the larger it gets, the weaker it gets. And a heart muscle that gets large and unfortunately becomes weak, there are certain medications that may be able to, allow that heart to function better. And there may be some regeneration as far as the function is concerned. But coming back to complete normal is probably unlikely. And I'm not a cardiologist, and Dr. Atherley is not here today, but the problem with heart failure is that usually other organs of the body are having a problem as well. And to say that all of this can reverse secondary to medications, it's unlikely. Okay. Dr. Aluya, you want to expand on that a little bit?
Can I jump in just a quick?
Okay, go ahead.
And it's the answer is it depends on the reason that the heart is enlarged.
Right.
Okay, that's number one. I just gave an example of someone that has chronic anemia, like a sickle cell. Okay, if someone has chronic anemia and there's no cure for the chronic anemia, then the normal function of the heart is to pump larger, and so it dilates. The muscles aren't enlarged, but it dilates. And so if you look at an X-ray and you look at what they call the cardiac silhouette, which is the size of the heart as it looks there, it looks like it's big because but it's mostly because it's dilated. Now, if you came up with sort of a cure where now the hemoglobin that the patient baseline was 6 is up to 12, then that heart could come back because it no longer has to be pumping the same volume of blood. If the heart is enlarged because it's developed increase in the muscle size because of hypertension over time, my guess is that if you were able to decrease the blood pressure and keep it normal, it might make some accommodations. But the likelihood of it getting back to its actual normal size after it took years to get bigger is not great. Now, if it's large because you have a problem with the actual muscle, there's something called cardiomyopathy, where the muscle itself is abnormal. And I don't think that there's a cure for most of the cardiomyopathies. Not only is it big, but it's not functioning very well. And so if you have cardiomyopathy and it gets bigger, I'm not sure that there's a way that you can ever get it back.
Dr. Sprout, explain
I'm gonna
cardiomyopathy.
let
That's a
Nelson
big
take
word,
over.
brother.
I was just wanting to make that one point about the reason of why. Nelson?
Go ahead.
Yeah, I mean, I think the heart, the whole concept of an enlarged heart is fascinating because I think it goes back to physics when they talk about, I think it's Starling's principle or Starling's law, and it relates to these cross member fibers. So as you stretch the muscle, it contracts more. But if you
Young
stretch
model.
beyond a certain point, it stays dilated. And so when we talk about an enlarged heart, what's implied? That's implied that the largest heart, but it doesn't mean it's not functioning, right? But as it dilates, as Dr. Sprague said, more and more to compensate for either pressure or the need to pump more blood because of a condition like an anemia, it pumps harder. But at some point, the muscle stretches beyond, for lack of a better term, the point of no return. So instead of returning, it stays stretched. So that's the challenge for our cardiologist, is now how to take that muscle that's now stretched to make it pump even more. And that's where medication comes in. The medications, I think, will influence function, not necessarily the heart size. Now, like every other muscle, the bodybuilder goes in the gym and he does reps and his muscles get big. Well, guess what? In certain situations, the same thing happens to the heart. And that's when we talk about hypertrophic cardiomyopathy. So now you have this heart with this big, strong, thick muscle, but it's not so compliant that it can stretch to fill enough, acquire enough volume. So now you have effective pumping going forward to feed the organ systems that it needs to feed. And in that case, that's also a kind of heart failure as well. And I think we see it sometimes in certain athletes, right? Dr. Spratt, this is not, I often say I break hearts, I don't fix them. But that's my understanding of the two different types of heart failures.
You're so right about that. And you touched on something, hypertrophic, cardiomyopathy, where the chamber itself that holds the blood becomes small because the muscle gets so thick and it's ineffective as far as pumping blood forward. The question also
if I may
stated
say
was,
something,
just let me say this, and then
Okay.
I'll let you jump in. It also stated that with medication and lifestyle changes, understand that there are certain medications that will, depending on, as Dr. Sprock said, depending on why you have the heart failure or why the heart is enlarged, there's certain medications that could definitely improve that. And also lifestyle changes, definitely. If you're overweight and you lose weight, if you have a lot of fluid in your lower extremities or your legs and you're taking water pills and getting that fluid off, there are many things that can make you feel much, much, much better. So I wanted to just say that to be complete with the question. Dr. Aluya, go ahead.
Yes, if we must remember that the heart is one organ that beats all through from when we start life until when we die. So it's one organ that never stops working consistently. And some people will say it begins at age, 6 weeks, when the heart starts begin to beat, until when you
Well, that's when it's recognized, right?
or recognized, right, to be from 6 weeks. Now it
6 weeks of gestation, not 6 weeks of birth.
No, 6 weeks of gestation.
Right,
That's
right.
Yes. So it continues from then, all through to when to adulthood, until when we're no longer here. Now, what that means from the beginning, where the conception and life begins, when it begins to beat. Now, in utero, inside the uterus of the mother, when the baby is still growing, the muscle fibers are usually much spread apart like this. But as the baby begins to grow and mature and reach the point where the baby is being delivered, the muscle fibers tend to come together and begin to really bond, so that it sets to a point where it can beat for you all through your life. Now, however, a few people may not completely bond completely together. And all through that heart is not programmed to live. It's like almost like red blood cells. The cells of sickle cell don't live more up to 20 days, or why others live up to 3 months. Almost like that. So that heart can only beat for, who knows, maybe 20 years, 30 years, 40 years, until something is done about it. The first case of heart transplant in the state of New Jersey was a young man who was 15, and people thought he had asthma. No, he had heart failure, because it was very rare to you to have heart failure in somebody that young. But eventually, what we found out was he has what they call non-compaction syndrome. And that means the heart valves or the heart muscles are not fused completely together. Now, for those who fuse completely together, it beats to the end of the life. However, one or two things can happen. And like you said, often enough, most hearts are very resilient, meaning they go on and continue to go on because they want to sustain you to be alive, even when problems are at the background, anemia, high blood pressure, or other issues, or even there's an infection. They continue to blow on, the beat on. But they beat up to a point where it becomes detrimental even to the tissues of the heart, that they can no longer beat on. And that's what you call the dilation that we talk about, which is the stretching that Dr. Anderson talked about. And in physics, you get to a point, it's called the Young modulus. Once you cross that level of the Young modulus, the heart is stretched out like a balloon. You blow a balloon out to a certain extent, it stretches out. It never completely goes back to what it used to be, because it took time over time to get there. However, for those who've had sudden heart attack, maybe you're young, your heart's been functioning and all that, and you have sudden heart attack, and you can fix that, those kind of heart can return quickly with medications and lifestyle modification. But with those ones who's been stretched out completely, it's almost never going to come back. Now, how do we measure it? Like I talked about earlier on, when we do the echo, they check the power of the heart, they check out the walls of the heart, the valves of the heart, and everything else. The power, on the average, between 65, it shouldn't be more than 70, but between 55 to 65 is what we call normal. If it's too low, it's bad. If it's too high, it's bad. But by the time the power from 65 go down to 55, 40, 30, then you're in heart failure. And those ones, it's just managing the case, putting your medications, changing your lifestyle, making sure that, and then doing cardiac rehabilitation so that you can handle and continue to function. Now, it gets to a point, if it doesn't, then they may have to put a pacemaker, God forbid, they go into an arrhythmia, it helps control, and also help, prop the heart to beat a little bit. Now, back in the days, we used to have medications like digoxin that they give to help the heart to contract. How much of that is being done, we don't know. And for who does it work well for, we don't know. And even for us who are Black people, we don't know how much those medications were working for us. But we now have, what do you call it? The medication called Bidil and everything else that did so much well for us as Black folks. The reason that Bidil did so well for us is because of the nitric oxide or the nitric oxide in it. A nitric oxide is a potent vasodilator. Now, it's been said that we as Black folks, we don't have enough nitric oxide in our lungs and our heart. That's just the genetics. Maybe because by the time we moved over here 500 years ago, we haven't adjusted to the environment to produce our own nitric oxide. Because way back in the continent of Africa, you don't need the nitric oxide per se. So when you give them here, in temperate region, they tend to do well. And that's the reason why these medications have been added to help augment treatment for us. Now, if all of this fail, they would put the biventricular valves that they tend to, or they push on to heart transplant. That's, again, another total a different topic for another day. But primarily, the most important thing is, one, know what your heart status is. But knowing what your heart status is begins by knowing what your blood pressure looks like. What's your standard? Because everybody are genetically programmed to have what you have. And you need to know that. One of and I'll tell you a short story. As a professor at Rutgers back in the days, I had a young lady who was brought into the clinic in the EL, and I had to go see. And they're like, oh, she came with a fever. Her blood pressure was really low and all that. She was admitted into the city, not city ICU, the telemetry unit. And the resident presented a case. And I looked at this case, and I looked, she was young. She was 20-something years old. So when I got there, she was sitting down, huffing and breathing away in bed. And one of the first questions I asked her, and I said, do you have a baby? She said, yes. I said, how many? She said, 3. So I said, okay. So what's your normal blood pressure? She said, oh, it's 95/60. But guess what? When the young slim, and that's one thing we need to understand. If you're on slim build, a majority of women who are slim built tend to have a lower blood pressure in the 90s. That's where they are. But if we don't know that, then it becomes a problem. So she went to the ER, high blood pressure, fever, very lethargic and all that. And they checked her blood pressure. It was 95/60. They gave her IV fluids, the bolus stuff, multiple times to raise the blood pressure up because they thought she was, going to shock because of the fever. But she wasn't. And all that amount of fluid that was given to her was too much for her body. So what was she happening? They were all backing up into her lungs. And that's why she was having problem breathing because the fluids were now in her lungs. So, and I just said, listen, the resident, get me a chest x-ray, give her IV laces. And you're going to see she has pulmonary edema. And that's exactly what it was because she knows what her usual blood pressure is. So at the end of it all, we need to know what a standard blood pressure is so that when there's deviation from it, if it goes high, we know why. If it's going low, we know why. And exercising is big for us, especially we people of color. Big time. Because in our hearts and our muscles, which is very different, we know with genetically programmed to be really different, we produce more of those nitric oxide when we move them. And that's why it's really important we know this.
Excellent. That was a great story. And I think everyone got something from that. Let's do the next question. The thing of it is that let me get this one. Is there a problem when the top blood pressure number is much higher than the lower blood pressure number? And I'm assuming that, you shouldn't assume, but I'm assuming that this is a senior asking this. And the blood vessels, as we get older, they get stiffer, and the top number can be much higher, and that range between the top number and the bottom number can be larger as well. Dr. Sprock, are you familiar with this at all? I know that I see it sometimes, but
I think I would sort of go back to sort of what Nelson has said and we've said all along, and that is what's kind of the normal variation for an individual. And I think that again, your body likes things to be normal. It just everything, and it likes for things to be in balance. And so in general, I would say that what has the blood pressure been all along for, in the visits that they've had? And is this something that is quite different than before, and what? And so I would say that he should talk to the physician about what has been the normal range of his blood pressure and what's normal for him, and whether or not this is something that is, unusual and different or not.
Right. I agree.
Yeah. So I mean, like you said, Dr. Bay, as we grow older, the walls of the vessels get, atrophied. It's just part of the aging process. Now, everybody ages differently. Somebody saw me yesterday. We talked, and like, oh, I can't believe what your age is like, Dr. Luya. I thought you were so much younger. And what's your secret? So I had to tell them, like, listen, I eat less, I exercise every day, and I eat a whole lot more fish. So, but that's who I am. So, but the question is, what's your aging process? And how do you know that? You can look back in your family as well. What's your family members look like? Because you share the same genes with them. And if that's what they look like, that's most likely what you're going to look like and head out as well. So the first step is one, you have to come and have a decision with your primary doctor, know who you are, what your status is, and take concrete steps to helping you reduce the risk and the process of aging. And one of that for us as a people is exercise, period. There's no double way around that. And eating well. Eating well. Because the kind of food that we eat are pro-inflammatory, especially here in the United States. Processed foods. And those processed foods tend to increase the inflammation that is in us all the time. And unfortunately as well, those of us who live in temperate area here, vitamin D for our skin, there's a reason why we're black. And vitamin D plays a huge role for the black individual because we absorb more of those vitamin D when we're exposed to the sun and good sun as well. So because vitamin D has been shown to reduce the innate inflammatory process that's in each and every one of us. It's also been shown to reduce the risk of high blood pressure. Reduce the risk of diabetes. So if you have pro-inflammatory state, you're constantly inflammation, it therefore means the inflammatory process is also taking place in the walls of your vessels. And those walls would age faster. And as they age faster, the resilience or the compliance, meaning if you need them to stretch, when you get up to exercise, they stretch out well and they bounce back. They stretch out well. As we all age or have a process of disease that restricts that, the compliance is much less. So pressure begins to set in. Now, for those numbers, the top and the bottom one is usually the top one that goes up. And that's why for us as elderly, you tend to see that number go up far more than the bottom one. So, and that's the one that puts most people at risk for strokes. Now, the ones that put people at risk for other issues, for instance, the kidney failing, is the mean arterials, which they talked about before, the top and the bottom one. And then the one that puts people at risk for heart attack is usually the bottom one when it's really very high. So we've come over time knowing and understanding what are the risks. And that's why you find out that for most elderly people, that people who have stroke are more elderly than those who do not. So controlling those is important. And that's why one of the ways of modulating that, again, for the elderly, is going on exercise regimen. At this time, you're not going to go, lifting heavy weights, just stretching, making things a whole lot more complex. That's how it is.
The thing of it is also, I think of atherosclerotic disease and hardening of basically, let me just say, hardening of the arteries as we get older. And they're not quite as compliant. And when they're not quite as compliant, when the left ventricle contracts and pushes that blood out, that pressure increases dramatically because that blood vessel is just not as compliant. And I find that in a lot of times in my seniors, that top number may be a little higher, and you have to regulate and understand that it may be a little higher, and there's not too much sometimes you can do about it. You can give blood pressure medication, but the question is, do they actually need? It all depends on how high is high. If you have a person that comes in and their blood pressure is 180, then obviously that's a hypertensive emergency. You're going to do something about that. You're going to send them to the ER. You're going to give, maybe as a primary care doc, you may give something in the office right away and send them to the ER. But yeah, I'm just talking about variations that would be maybe on the fringes of the bell curve, not hypertensive emergencies.
Omar, just one other thing, just for definitional purposes, the difference between that systolic and diastolic is called the pulse pressure. Okay, and there's a standard. And so if you think about, this systolic when it squeezes and the diastolic when it relaxes, you can have variations in terms of that pulse pressure if you have issues related to, especially the aortic valve. So remember, the aortic valve is the valve that goes between that left ventricle and into the aorta. And if that's a problem with it, where some of the blood that's supposed to go out comes back down, then there may be an issue in terms of that pulse pressure. But as you said, if you have atherosclerosis and you have vessels that are not so stretchable anymore, you can have problems related to it. But there again, I think the issue is it gradual over time or is it all of a sudden?
Right.
But I think if you talk to the doctor may want to refer him to a cardiologist to make sure that there are no valves involved. Especially, you can sometimes tell by listening if there are issues with heart valve.
Right.
Excellent. Patrick, we got a question that's coming up for you here. I recently had a breast biopsy as a result of a small mass discovered during during my first mammogram after I turned 40. Thank God everything was negative, came out negative, it says. But after 2 months, I am still having pain at that same area where the biopsy was. Should they be concerned?
I think that's more related to possibly the trauma of the biopsy itself as opposed to a disease process within the breast. One of the things you have to understand that the breast is full of very fatty tissue. And when a biopsy is done, whether it's done with just a needle or it's an open biopsy, oftentimes there's a space and there's what we call some fat necrosis or the inflammatory reaction around the biopsy site. The fluid fills that space. And sometimes that inflammation can cause pain, which can go on for a long time. What's important, though, is the actual result of the biopsy, because that can speak more to what's going on locally in the breast than the actual process, even if it's non-cancerous.
Excellent, excellent. The next question is, thanks, Patrick. The next question is, my dad, 85, and my mom, 76, recently discovered a pain in their heart. And when the doctor examined them, discovered they had fluid in their, as they say, fluid in their heart. And further says that this is a result of blood pressure medications. They are taking this water pill called, they are taking a water pill. Hold on, I want to make sure I get this question right. Blood pressure medication they are taking, water pill, retaining fluid in their heart. How can we avoid this type of medication causing retained fluid in the heart? I'm not exactly sure how to put this together and answer this. A water pill, usually the desired effect of a water pill and what it does is allows you to urinate off extra water. And usually when patients have extra water per se, for instance, I'll give an example of the lung. If the lung has what we call pulmonary edema or congestive heart failure, or in the lung tissue itself, there is extra fluid. We give a water pill that causes the kidney to pull water into the bladder and you urinate it off. And this decreases the overall amount of water in the body, as well as clearing some of that extra fluid out of the lungs so that you can breathe better. That's the usual effect that water pills give. When they say, when the question is stating that there is fluid in the heart, sometimes what may occur is there may be fluid around the heart, which is called a pericardial effusion. And the heart sits in a sac, and that sac has a small amount of fluid around it, in it, and that kind of bathes the heart. But when that fluid gets to be too large, it constricts what the heart is able to do, which is contract and dilate to push blood through. It does not sound like from this question that there is, say, symptomatic pericardial effusion or effusion around the heart. I'm not exactly sure what the doctor means by this question. Dr. Aluya, you have your hand up. Maybe you can help us out and try to explain some of the things that Lasix does and water pills do, but I've never heard of a water pill causing buildup of fluid in the heart, but I may be wrong. You go ahead.
Right. So, well, before I answer the question, I want to recognize Dr. Bola Omotosho, who's been here for so long. He's a great and amazing doctor up in New York. So, Dr. Bola Omotosho, thank you for staying on. Maybe one of these days we'll come have you come on so that you can give us your expertise. He's very knowledgeable. I know that. So,
love to have him. Love to have him.
Yeah, right. So, I think the question, that's what's referring to, because when you talk about, medications and water, there's some medications that make you retain fluids, and they are blood pressure medications. But however, it's supposed to help you reduce your blood pressure, but they also help you retain fluids. And that's why once you put them on it, just like some medications, once you start taking it, like the ACE inhibitors, you start taking, you have a cough or angioedema. Now, this medication is called a calcium channel blocker. Example notorious for that is Novas or amlodipine. You start the medication within a week, 2, depends, sometimes a month or 6 months after, they start retaining fluid. That's what it does. There's a process of doing that. Now, there are other medications that can also do that, but they're not readily common. One of them, again, is metoprolol. Metoprolol can help you retain fluids, but not very common in some people, because I'm sure there are some people who are genetically, have a genetic predilection to doing that. Another one is gabapentin. Gabapentin would also, we've used gabapentin so often, especially now we have diabetes everywhere. Gabapentin can make you retain fluid. So if you start somebody on medication, or you're started on medication, and you find that your legs, the ankle legs are getting swollen and all that, and they're puffy, go to your doctor, discuss the medication with your doctor, and say, Doc, which of these medicines can make me retain fluid? That's one. And then the doctor will say, oh, it's this one, and then they'll stop the medications outrightly. Now, in the process, they may also put you on water pill just to get rid of the fluid that you have retained. Now, often enough, the retention of the fluid is not enough to get to your lungs where it builds, or even get to your heart around the sac that you talked about where it builds. Because you know why? That sac is supposed to be very sterile. Nothing is supposed to go in there. Not absolutely zero infection, anything. If anything goes in there, it causes inflammation, and the fluid and the cells around the heart, with the immune system, wants to get rid of it. In the process, they produce inflammation and create liquid around the heart. So that's what you just described. But for medications, none of them will get to a point where you retain, it gets to your lungs, it gets to your heart. No, it doesn't. Now, if you have leg swelling in your legs due to medication, does that mean your heart is weak? No, not necessarily. It doesn't mean so. However, if you're elderly and you have shortness of breath all of a sudden, then it's a good time for your doctor to get an echo as well, to look at the power of your heart and see what power is it. Is it 55, 60, 70, or whatever? Now, however, in the absence of anything else, if you all of a sudden see that your legs are getting swollen, and one of the ways I let people know to know how their legs swollen, push down on your leg, lower leg, around the shin, press it with one finger down, and count to 1, 2, 3, 4, 5. And if you see if it's indents, if there's an indentation or it depresses, it therefore means that leg has fluid. You do the same on the right one as well. If it's on both sides, where you have the indentation or the depression, it means one, the heart is having a problem, the kidney is having a problem, or the liver is having a problem. Any of those, you need to go see your doctor and have a discussion with your doctor. Thank you.
Omar, I think, the way that the question was worded, in terms of fluid being in the heart. When we talk about the heart, the only fluid that's in the heart is blood. that's moving to the lungs or from the heart out. But as you said, more likely than not, the question was related to fluid that's surrounding the heart. And you talked about the pericardial effusion. Now, there are some medications that have been associated with pericardial effusions. And so that may be what he was talking about. When you talk about, I'll say, fluid retention or medications that cause fluid retention, again, I'd early mentioned that when you're talking about edema, edema is excess fluid that's around the cells. And in general, that means there's excess sodium, that sodium's being retained. And the kidney is responsible for sodium retention, and it's responsible for sodium retention sometimes because it believes that there's a problem with the blood volume. And it could be because of the distribution of the blood volume. And as Dr. Aluya said, one of the things that keeps a certain volume of fluid within the blood vessels is related to albumin, which is a protein which may be related to the liver. But when you're talking about edema or excess fluid, which means excess salt, you need to understand whether or not it's generalized edema, which means it's all over the body and all parts of the body are retained in it, or whether or not it's localized. And sometimes the localization of edema can relate either to, I'll say, heart failure, and depending upon which part of the heart is failing, you can have a backup of pressure that leads to generation of fluid, or it could be localized to the lower extremity. So individuals that might have a blockage of either a blood vessel or a clot might have localized edema from where the clot is and beyond. But I think that there may be an issue related to if this is pericardial effusion or not. And when Nelson spoke about inflammation of that pericardium that leads to cloudiness of fluid and everything else, that can be an issue. But I think fluid in and of itself that may not be causing problems because of the volume is not significant or not, could be related to some different types of medications. And there's some medications that might be used, hydralazine or minoxidil or isoniazid, are sometimes associated with pulmonary effusion that may not have anything to be treated for if it's just a small amount of fluid. If it's a large amount of fluid, then the question is whether or not you drain it or whether or not you can stop the medication that might be associated with it. But I would say that more likely than not, they were referring to pericardial effusion, which is fluid, not generalized edema. And again, using a diuretic for a pericardial effusion is probably not going to be helpful.
No, yeah, it's not going to be helpful. The thing of it is that for what I understood, the water pills may have been, they thought it was the cause. It was the.
I know, but I'm not.
Yeah, it just didn't. I was trying to make sense of the question. Yeah. Let's.
Hydralazine is something that could be associated with an infusion, but
yeah. One of my favorite blood pressure drugs and medications, I should say, blood pressure medications back in the day in the ICU was, especially with renal patients, hydralazine. I love it. Okay, the next one is, and we have a lot of questions, is there a system that shows the patient's history when patients go to the ER before anyone can treat them? So I'm thinking through this question and I'm trying to understand a system like that would be a medical records system. Whereas if you were a patient of one of the physicians of that hospital, then before you get there, yes, they have your medical records in the system. But if your doctor is outside the hospital system and they have a medical records and it's not connected to the hospital, they may not have your records prior to getting there. But does someone else have a different take on this question?
I think the other aspect is whether or not you have the information as part of your access to a patient portal.
Right.
Because in general, if you go to a practice that has access to a patient portal, they'll have your laboratory results, they'll have the results of some of your scans. If you have echoes and things like that, they'll have access to it. But in general, the physician in the emergency room won't have access to that unless you allow them to have access to it, or you can show them that they have values that may be important for them to see. But you can access your patient portal from your phone in general and provide them with information if they ask you specific questions that's there. Because there's a lot of information that's part of the patient portal, and it goes back for several years. So it's not your entire medical record, but it contains a great deal of information that might be useful to an emergency room physician. The emergency room physician won't normally go to that before they see you because they're on the clock and they're looking to try and deal with it. But they may have information if you provide them with access to it that they can look at and see and might help.
Yeah, I think that's one of the
I didn't
advantages
think
of
about that aspect, Ken. That's great. Patrick, go ahead, please.
Yeah, I think that's one of the advantage of having an electronic system, of which patient portal is a component of it. And even across different healthcare systems, if they have the similar medical record system, and at risk of advertising issues, for example, Epic, multiple healthcare systems can have the Epic, and with Epic, I can see records of patients who will get healthcare in Manhattan. I can read physicians' notes. I can see, like Dr. Sprock said, studies, whether it's blood work or echoes or X-rays, CAT scans, whatever. So a good electronic medical record platform is one way to have your essentially universal access to your health records.
Excellent. Dr. Aluya.
Yes. So just like Dr. Anderson said, when I think during the Obama era, in its process of revitalizing and addressing the issues of healthcare industry in the United States, everybody was moved on to electronic medical records. And unfortunately, the United States has been slow and behind in a lot of things that are innovative in this space. And that's why, in all sincerity, the US is like number 20, whatever, in most developed world when it comes to healthcare delivery. Because at the end of it all, what this depicts is that unlike in Europe or everywhere where they have a common, payer system, anywhere you go, the ER or anybody can see what's been done to you or for you, and it can follow up. And I'm glad, at least here in New Jersey, Epic, is taking a huge form where they're creating this big system. And once you are in Epic, you can have access to anything else. And like I said earlier on, when patients go to the ER or they're going for surgeries, and most doctors on the outside don't even know what happened to them. If you log on, anytime you log on, your patients anywhere that's assigned to you gets anything done in any of the systems that's associated with that healthcare, it will flag up and you'll be able to see it, which is good. However, if they go somewhere else, you wouldn't. Now, what has really happened over the years is this. I go to one hospital A and I get a headache and they do a CT scan or X-ray for me. And I go out to another one, which is a different system, and I would same headache because I wasn't, really sure or wasn't satisfied with what they did to me there. I go to another one. Guess what they're going to do again? Another CT scan and probably another X-ray, right? And this has been going on. And then they drop blood work again for the same thing that was done in, hospital A. And if next week I go to another one, the same thing will be done again. Have we actually look in our system and see what this is doing to our patients? Understanding now that, especially in our community, we have an increased rise in thyroid cancers. Who knows? And even breast cancer will begin to, and that's why I tell my patients when they say, "Oh, doc, I think I need an X-ray. I think I need this." I'm like, listen, these things are not all benign. the more you get exposed to all of these things, you never can tell what you do to you because it's ionization of your cells. It can prompt a cancer. It can prompt anything. You may be having a viral symptom, a cold at that time, and then they radiate the whole thing with the cold and the virus. The virus goes crazy. So you never can tell how these things are. So hopefully, they've been processed where they're egging everybody to have a system where wherever you go, at least we'll be able to see what is being done to you. I hope we get there someday, and we pray we get there. Thank you.
Yeah, that's the beauty of the portal. You know, the patient carries his or her records with her wherever she goes. And, you know, Dr. Sprock and I in 2 different locations can see what each other have done to or for a patient, you know, through care anywhere aspect of a medical record.
Right.
And to me, that's a beautiful thing. The other thing that I think is beautiful about it is the ability to make requests. So, you know, I through one set of entry, I can send information to an insurance company for authorization, for example, and I schedule the patient for a test or a procedure almost simultaneously. So the hope is that, you know, this also improves efficiency. But I might tell you this, with that kind of efficiency, there comes automated oversight, which means you can look at your personal dashboard as a physician, and all of a sudden you see this audit that your average time to document is 4 minutes, right? Your average time to see a patient is 10 minutes. So it also helps us to organize in ourselves how much time are we spending with patients, disseminating information, educating, but that in of itself may not be documented. So the efficiency is great. There's the ability to improve quality, but all that comes with additional oversight.
Right. True,
But
true.
AI will fix a
And
lot of
sometimes
things.
the amount that you get paid is related to your efficiency in terms of seeing
Right.
patients and generating bills.
Right. Right.
Right.
AI will
That is
fix a
true.
lot
That
of
is
all
true.
those things.
Let me
Move on.
we're almost out of time, and I have a few more questions. I really want to get to these last couple questions. They're interesting. My hemoglobin A1C has been in the pre-diabetic range for many years, as high as 6 and as low as 5.5. What can I do to get back to 5.5 and keep it there? I exercise and walk 4 days a week. Now, Dr. Luya, I'm going to have to apologize because we were supposed to get to diabetes, but you know, hypertension is a big issue. So can you promise to come back next month and do diabetes?
Yeah, as a matter of fact, I would love to do a short presentation before we talk about diabetes as a whole, so that people get a concept of what diabetes is,
All
and
right.
then you'll be able to channel them, you know.
No, but we can do it in many ways, but I just want to make sure that we cover it because that is as important to our people as hypertension.
Right.
And we have to cover it. We have to cover it from a basic, very
Point
basic
of view.
formula. All right, that's that. But let's deal with this question. So he's his hemoglobin A1C is usually around 6, as low as 5.5. What can he do to get it back to 5.5, which is normal? And keep it down there, which he exercises. I'm not sure what his weight is. I don't know how he eats. I don't know, but those type of things. But you're the man right now.
So I'll give you what the average is in this country. On the average, by the time you get to the pre-diabetic stage, which is 5.7 onwards, from that point on to where you become diabetic on the average takes about 5 years in this 4 years in this country. So if you keep an eye watching from 5.7 and you do nothing over it, you'll continue to go on. Now, for those who have exercised, made changes in the diet or whatever they do, and that's why for this individual who I will presume is a person of color, that's the reason why he hasn't completely gone over yet to becoming full-blown diabetic, because he's exercising and watching his diet. Now, if you take a look at the family history of probably of this individual, I presume that majority of the family members are already diabetic, plus or minus the complications of diabetes. So you're doing the right thing. What you need to do now is even more. either as we grow older, our exercise regimen becomes it becomes complacent. What it means is you get to a point where whatever you're doing every day no longer makes any change. It just becomes routine. You may up to, step up a little bit. That I had to do that recently myself because I realized I do the same thing over every day, and then all of a sudden I find like, oh, okay, I'm budging here, I'm budging there, so I have to step up. That's one. Two, watching what you eat. Increase more green vegetables and all that. Less bread. Bread, in my experience, is huge when it comes to the risk of diabetes because of, there's a whole story of what they call it, millet or all the other things they use in making wheat. There's a whole story about that and how it produces individuals to diabetes. So cutting back on the bread, cutting back on rice, increasing your vegetable, eating more fish would definitely do that. But stepping up your game in terms of exercises, because those of us who are people of color, our muscles eat when we move them. A gentleman came in to see me earlier on today because I asked him, he's pre-diabetic, and said, listen, you need to start exercising, you need to start, going to do, activities, increased activities. So he's like, okay, fine, I'll do that. He came in today, he's like, doc, I almost died. Like, what happened? I went to the gym and I got on this machine. I just cranked it up. I was going on and going on, and I felt I was feeling good, and I just kept on cranking up the speed, and I went on for 45 whole minutes, and then all of a sudden I felt like I was gonna die. So I'm like, did you go down? He said, no, it was my first time. I just thought I should just do this and get it over with, and build myself up. And then he said, doc, I don't know what happened. For the next 2 to 3 days, I couldn't even move. My muscles were so weak and all that. I said, listen, first and foremost, you haven't been doing that. If you have to start exercise, you have to do it in graduation. You have to slowly build it up. That's one. Two, for you, a Black Nigerian, your muscles eat, and you're very bulky. Your muscles eat when you exercise them. You went there, did you eat? He said, no, I didn't eat. I said, yes, that's what it is. So your muscles ate up all your sugar, and there was nothing left. You just built lactic acid and other things that made your muscles really weak. You understand? So I said, did you drink water? Like, no. So I said, get hydrated. You do 5 minutes, 10 minutes, you relax, let the body rebuild itself to do that again. So again, that's who we are. That's our genetics. And I can always say this, there's a reason why the fastest people on earth, both male or female, are Black. There's a reason why. Not because we exercise more, not because we have more money to train or we have the equipment. No, it's just our genetics. So we move, our muscles eat, we break down sugar, period. So all the steps, like I just advised, will be good. Exercising, upping it up, more green vegetables, cutting back on, refined sugar and products.
Excellent, excellent. Let's do this, and we're going to make this the last question. Post-COVID, do you see an uptick in more heart failure diagnosis? Can you give a little info on the change, on these changes? So I can, from a pulmonary standpoint, I can say there are long haulers as far as COVID is concerned. That's for sure. As far as heart failure is concerned, I'm not sure. And Dr. Atherley, next time we do this webinar, Dr. Atherley may have to answer this question at that particular point. But from a pulmonary standpoint, I do feel that there has been post-COVID and people getting over the acute episodes of COVID, there were pulmonary emboli. And pulmonary emboli occur, and what it is when those blood vessels, those pulmonary arteries are blocked by blood clots. And it makes it very difficult for the lung to distribute oxygen to the bloodstream because those blood vessels are blocked. That I have seen. But I'm not, I would have to refer to Dr. Atherley as far as cardiac and heart failure is concerned. Dr. Aluya, your hand is up.
Yes. So one of the things that COVID did to us, outside of leapfrogging us 7 years ahead, meaning it just advanced technology 7 years ahead. And that's why what we used to do, what we do now, we used to go from town to town to doing this, right? But COVID made it possible for us to do it online. So people from Nigeria, from Canada, everywhere can watch. And that's the leapfrogging it did. But it also did a couple of things. It helped us understand our body physiology as a response in modern day time to viruses. One of the things that viruses do, and they do well, they infect tissues. And we got to understand how viruses affect every tissue in our body, from the cell to the transport system, to the Golgi bodies, to the nucleus, whatever it is in the cell. Viruses do that. And every cell is infected. And the same thing that the COVID virus does as well. Notorious for what it does, it affects the myocytes, the muscles, the tissues of the cells of the heart. It really does that. Just like adenovirus. I'm sure Dr. Sprott will see that, and he's done that, where adenovirus would affect the tissues of the heart, which is the myocardium, to the point where it causes dilatation, the stretching of those. And how does it do that? How does it do that? It creates an inflammatory process to the point where each tissue bond within the cell, if they were like this, the inflammation causes the separation of the individual strands of the cell to a point where it stretches without normal due process of high blood pressure or anything else. So what we've seen over time is that as the process, as the virus affects the tissues of the heart, over time, as they begin to heal, that healing process causes fibrosis within, the spaces where it stretches out, and they come in to have heart failure. We've seen that, and it was something we didn't recognize, but we truly begin to recognize it as it may be as well. We never really saw where the myocardial infarction. Yes, it does happen, but that's not as bad as what we see with the myocardial cell inflammation that really does take place. So affecting the valves, yes, it does, but not as much as the tissue itself, as we see. Receptor cells, again, that's another issue. When COVID first came, and people were like, "Oh, I can't smell," or "I can't taste," we thought it was initially the nerve itself that was being affected. No, we realized down the road it wasn't the nerve, it was the receptor. You understand? Of the cell that was being infected. So that's why as new receptors grow, they begin to recover. Because if it's the nerve is damaged, is done. But as new receptor cells grow up or grow, then they recover. And that's why a few people recover. Those who couldn't produce new receptors, they didn't. Now it may take 2 years, 3 years, 6 months, 2 months, 2 weeks, for those to recover. So that's how we got to know a lot of all these things.
All right, excellent. As usual, this has been an excellent webinar. Boy, we got good questions this time, and I'm so happy for the questions coming in. We got to get more questions from the audience, because that's who we are here to serve, and we're here to answer those questions, because that's what education is all about. The other thing is that I will be sending out, and watch for your emails, everyone. I'll be sending out information as to what our topic will be next month. Hopefully, Dr. Aluya will be around and we can make it diabetes, and we'll have a discussion about that. Dr. Aluya, right?
Yes.
All righty. And
Omar, if I may just ask, as a follow-up to hypertension, which this is fantastic. And I think we're just scratching the surface each time we have these discussions. Is how do these chronic illnesses contribute to maternal mortality? And we can talk among ourselves and source the expert who can come in. And I can speak in a general sense, but for this particular topic, we need that maternal fetal medicine expert, and we can talk about how we can source that individual.
All right, yeah, definitely, Patrick. We'll talk about that. All right, that's needed, especially for our females, and things that are occurring to them from a medical perspective. Definitely, we need that. All right, we'll talk, Patrick. In closing, in the closing remarks, thank you to OBHealthy for allowing us to bring this program with this webinar to you. I'm just so thankful for them that they're reaching out to us and allowing and not pulling us back or anything like that. They're just letting us do our thing, and so that we can educate our people and our population. Remember, this webinar is every second Saturday at 1 o'clock. And please, all I can say is, it takes a village. Let friends and family know any way you can via Instagram or, Facebook or, LinkedIn, whatever you're on, whatever social media you're on, let them know about it, so that we can really gather information, push it out to our community so that we can live longer and healthier. Okay. The most important thing, and I always say this, and I mean this from the bottom of my heart, do not change any aspect of your medical care until you consult your physician. Only your doctor can truly take care of you from a medical standpoint, all right? To view our past webinars, please just go to OBHealthy, hit the YouTube sign, and all our past webinars are there. Great information, all righty? I just want to say thank you for joining us. Physicians, thank you for taking your time, because I know how important and how valuable each of your time is. And we're going to see you next month, same place, same station. Thank you again. And yeah, all I can say is peace. Enjoy the next month, and we'll see you 1 o'clock next month. All right.
Thank you.
Take
Thanks,
care.
everyone.
Take care.